Dr. Martins gave most of my lecture in his case presentation, so it'll be a lot more quick, it'll go more quickly than we thought. Where's the pointer thingy? Oh, here it is, I'm sorry. Okay. Okay, anyway, hi, good morning. I'm going to talk about menopause and hormone therapy, try to add a couple different perspectives on it, and I do have some other things besides what has already been discussed, so we'll go over things. I don't really have any disclosures other than the fact that I am not Dr. Bachman, who is my boss, my mentor, and my friend, and is very sorry that she couldn't be here with you this week. We're going to review briefly the physiology of menopause. I'm going to go over clinical implications. I'm not going to go over too much perimenopause because of time constraints. Focus more on postmenopause, hormone therapy. Going to look at hormone therapy from the scientist perspective, from the clinician perspective, and then from the patient perspective. So we'll start with physiology. Physiology for menopause. It's all about the eggs, right? Remember, menopause happens in the ovary. Menopause is about losing eggs. This is a slide that I know we're all familiar with. We're all familiar with the cycle. So yes, we need the eggs, but we also need the brain and we need the uterus. And it kind of is all connected, but we don't have any of this without the egg. And what is menopause? It's really all about egg depletion. We're born with the most number of eggs we're going to have. We deplete eggs as we go through life, so we're kind of born heading towards menopause. So abrupt decrease occurs around 35 or 40, which again is important because of our fertility discussions. And we lose our functional follicles relatively young age, around 51.8, which is the average age for menopause right now. The life expectancy is 81 years. So let's do a math problem. 81 years life expectancy minus 51.8 follicle depletion leaves us 29.4 menopause years. And we need to take care of ourselves and our patients during those 29 years. It's more complicated than that. So we have that 81 years. Can we and do we impact that with hormone therapy? 51.8 follicle depletion. Again, we have to look at that fertility decline around the age of 35 because women are looking to have babies at an older age. And the average perimenopause is 3 to 5 years, which can be a very difficult time for many women. The menopausal years, I'm going to break that 29 years down. The first 2 to 3 years I always like to think of as those are estrogen withdrawal symptoms. That's when we're getting the hot flashes and we're feeling that loss of estrogen. As we'll discuss, that first 5 to 10 years after menopause is our optimal timing if we're going to treat with hormone therapy. And throughout that whole 29 years, we start having estrogen deficiency effects. Those estrogen deficiency effects are the bone effects, are the vaginal atrophy effects. I break things down in my mind. What you'll see as I give the lectures that I'm giving, I'm a very simple clinician, and a lot of the terminologies in the societies, they're way too complicated for me. I will mention them, but then I'm going to talk more in a clinical manner, which I'm much more familiar and comfortable with. But I think of it as you're either pre, peri, or post-menopause. Okay, that makes it easy. But if it's easy, we have to have a committee to make it hard. So we had the straw committee. And they decided that they were going to change it so that we can have a more complicated way to look at all these stages. And it very nicely summarizes how long the stage is going to be, which is variable, and talks about what you would expect clinically. So that's not too bad. Because it wasn't too bad, they had to try again. So in 2011, they tried again, and they came up with this, which added a lot more information to it. Clinically, I'm going to go back to premenopause, perimenopause, postmenopause, because that to me is what matters when somebody's sitting in front of me. Put this another way. We all know there are our nice cyclicity that we have when we're premenopausal. We come postmenopausal and we have nice lack of cyclicity, right? Or cyclicity, we're nice and flat here. We have only our high FSH level because that's our brain screaming at our ovaries to work. but our ovaries aren't working anymore. And then we have the perimenopause, and you just look at this and you're like, this is what our hormones are doing during the perimenopause. That, to me, is the most significant slide to show that checking any blood levels is really not very helpful. It doesn't really give us a lot of information. And what's interesting is it's the hormone variability rather than those absolute low levels during this period that corresponded with the menopausal symptoms. After menopause, it's the low levels, but here it's that variability that gives you all those perimenopausal symptoms. Clinical implications of the perimenopause, I'm going to summarize it right here. I don't know if that's the doctor or the patient, but I think it's probably a little bit of both. Perimenopause is when we have to look at keeping people, think of their eggs. What do they want to do if they want to keep their eggs? We have to look at their brain because they are not feeling well. They're getting all the menopausal symptoms. And we have to think of their uterus because they're having all that abnormal bleeding. We need to, one, fix their bleeding because for them, bleeding is not very fun. But for us, we're always concerned about the hyperplasias and the endometrial cancers from that excess of estrogen stimulation that they're getting. That's my whole summary for perimenopause because I'm going to move on. Again, that's a whole other lecture. But I am going to mention something that has come up much more frequently in my practice, and I'm going to call it the pre-peri-menopause. See, I did make it a little more complicated. And that's when you start thinking about decline in fertility. Age is still the single best predictor of fertility. People come in and they're asking me, tell me if I'm still fertile, tell me what to do, tell me if I need to freeze eggs. And there's not great answers for that. There are fertility predictors, the day 3 FSH and estradiol, which we've been using for a long time, which has limited reliability and is not very sensitive. The anti-Müllerian hormone, which you can test at any time through the cycle, low is bad, but it varies with SA. You have to look at your normal. The antral egg count, which is visible ovarian follicles between 2 and 10 millimeters during day cycle 2 to 5. Low is 3 to 6. And inhibin B, which will decrease with age, when it's low, the FSH is going up. But there's poor intercycle reliability for those tests. How do I remember these? We all know FSH is high. We all know high for FSH is bad, right? So all I remember is FSH is high, the rest of them low is bad. So high we remember and the rest are just low. What are the problems? How do you counsel if you get all these very expensive tests? Well, the AMH and the antral follicle counts are probably the most reliable. Combined is probably not much better than individual because I know there's a couple new products, at least one new product that patients can get that is supposed to be predictive of their fertility, which is a combination of those 4 markers. ACOG's comment on it from 2015 is, although these tests may predict ovarian response to infertility treatment, they don't reliably predict failure to conceive. Okay, and that's an important thing to remember. These tests were all designed and used by infertility people trying to predict how you're going to respond to an IVF cycle. So what do you tell people about egg freezing? Well, first of all, you want to tell them about egg freezing up here and not down here. All right, so that's why I call it the pre-peri-menopause. And let's do some more math. This is really good math if you're the egg freezing person. $6,000 to $18,000 per cycle. The egg storage is $500 a year. Thawing, fertilization, and embryo transfer is another $6,000 to $18,000 per cycle. Average of 8 eggs per cycle, but that's highly variable and highly age dependent. That's why you want to get eggs here and not eggs here. If 10 eggs are frozen, 7 will survive the thaw. 6 are expected to fertilize and become embryos. And then the statistics for how many of those embryos actually become babies is what's the average, about 30%. So it's a costly thing to do. Again, if you're going to benefit your patients who want to do it, they need to do it here so that they're getting their good bang for their buck. Companies are starting to pay for some companies are starting to pay for egg freezing, which kind of brought it more into the headlines. So what are our clinical implications? Now we'll switch over to menopause. Okay, first thing to remember is it's not hormone replacement therapy anymore. It's now hormone therapy. And the reason that this terminology has been changed, one, I think, is to make us a little bit more leery about giving it, remembering that we're not just replacing what people have lost, even though in my mind that's still what we're doing, but we're actually doing a pharmacologic intervention, so we should treat it like a pharmacologic intervention. Because it is elevating levels to higher than what they would normally be. I have a comment in risks of hormone therapy greater than benefits in most menopausal women. I don't know that I necessarily agree with that statement. I just put it in there because that's Dr. Bachman's belief, and I'm representing her a little bit, so I'll leave that in there. We differ somewhat on some of those things. What are the approved reasons for hormone therapy? Vasomotor symptoms, urogenital atrophy symptoms, bone health maintenance. It's not recommended as the first line. Again, the exception is, as Dr. Martin said before, is that the newer hormone replacement therapy with the SERM as replacing the progesterone does have a bone prevention indication. Okay. So let's look at it from differing viewpoints. We'll start with the basic scientists. I'm trying to keep people awake here. Okay. Basic scientists say all estrogens are not the same. Estrogen has different receptors. Again, Dr. Martin's alluded to that. There's different receptors in different places in the body. Different estrogens bind to those receptors at a different affinity, and they turn on different actions in the body. So all estrogens are not created equal. There's the alpha, which are uterus, breast, ovaries, and the beta, bone, CNS, lungs, urogenital. That's just a little basic scientist diagram. Why did the clinical implications of WHI, which we're going to talk about in a little bit, why are we changing what we're thinking about them? From the basic science point of view, what does estrogen do that's good for us in terms of heart disease? It lowers cytokine productions. It lessens response to pro-inflammatory cytokines. So when we lose it, we're going to do the opposite. The lack of estrogen is associated with a metabolic state that increases visceral adiposity. We lose our estrogen, we become more prone to the metabolic syndrome, which is a pro-inflammatory state. Again, just for those of us who are getting older, this depressing picture shows what happens as we age. The apple-shaped body is more of the visceral adiposity than a pear-shaped. Why does that matter? Because in early menopause, when we're first starting to lose that pro-inflammatory, when we're starting to develop that pro-inflammatory state, estrogen is helpful in preventing that. And the scientists looked at that. They looked at that in monkeys. It's much easier to look at things like that in monkeys. If they tried to give monkeys diet-induced atherosclerosis, it was prevented with early estrogen use. Again, we're preventing those changes from happening in the heart. Again, why? Because we're catching it before it leads to chronic changes. If you look at this in the blood vessel, why did estrogen in the Women's Health Initiative, why did it give people heart attacks, and why was it bad for their coronaries? Because they were starting off with bad coronaries. So what does estrogen do? It makes your vessels more pliable. It helps dilate them a little bit. What happens if you take something that has plaque built up in it and you make it pliable and you dilate it? You release the plaque. You've already got the disease and now you're almost activating the disease. And that's important to remember when we think about who we're giving hormone replacement to. The other basic scientist part of estrogen is the oral route is not ideal. Why? Because it hits the liver. What happens in the liver? Well, the liver does all kinds of good things for us, but it also makes all the things, it's the place of synthesis of all the things that can hurt us. Okay? It's the clotting factors, it's the binding globulins, all those proteins that can do bad things in the cardiovascular system. So the summary for the basic scientist is they want the non-oral route. Early use appears cardioprotective, and the loss of estrogen causes adverse metabolic changes. So how do we take that and we become the clinician and we advise people, well, what do we do about hormone therapy? We know that once you hit menopause, you have an increased risk of osteoporosis, cardiovascular disease, stroke, neurodegenerative changes, atrophic pelvic and skin changes. Remember, we have 29 years of those changes that we need to try to deal with. So for us, every time somebody comes in menopause with any of the symptoms of menopause, or anytime they're approaching menopause and you want to discuss it, it's all about risk and benefits. So our risk and benefits are major systems that we're looking at: the heart, the breast, and the bone, right? Those are our top three systems that we're considering when we think about estrogen. But it's also quality of life. Patients are very unhappy when they have hot flashes. It's very distracting. It really impacts their quality. Vaginal dryness, also a major quality of life factor. So again, for most people, do the risks really outweigh the benefits? Well, why are we so confused? I think for the risk of breast cancer, which we'll talk about in a minute, when WHI said that estrogen increased the risk of breast cancer, or estrogen and progesterone increased the risk of breast cancer, who in here was surprised? Nobody. We all knew it always raised the risk of breast cancer. But it was an acceptable because we said, well, it's so good for your bones, it's so good for your heart, it's so good for other things. So the real change came when they said it was bad for your heart. Because now all of a sudden, not only was it bad for your breast, which we already knew, but now it was bad for your heart too, which was one of the things we were using to sell it for. So why were we so confused about that? Why did it change so suddenly? Well, when we look back at the observational studies, it was always good for the heart, which is what we all learned. Okay? What was different between the observational studies and the randomized controlled studies, which was WHI? The difference was the patient population. Okay? Women in the observational studies were younger and starting estrogen right around menopause, whereas women in the WHI were older and they had not had estrogen around for many years in many cases. But when they did the data, everybody was clumped together. So it's the biological diversity in the patient, not the estrogen therapy, that caused all the confusion. So what we need to think about for estrogen is start it early. The woman's age and time since menopause is what's influencing her risk for estrogen significantly. Women at lowest risk near menopause with favorable lipid profiles are probably the best candidates for estrogen. So what does this mean to us? If they're less than 10 years, 24% reduced risk of heart disease, which is about the number we always quoted, right? Women 10 to 19 years had a 10% increased risk of heart disease. So what's that doing? It's targeting our patient population. It's helping that risk-benefit decision. Women with favorable lipid profiles, again, they had low lipid profiles. They were less likely to be going into this with heart disease. So we were perpetuating that protection as opposed to activating disease that was already there. Women with bad lipid profiles, they had a little bit of an increased risk. So with the heart, it's about timing. Bone is easy. I don't have to say anything about estrogen in bone. We all know bone, estrogen, good. That's all we have to know. Breast cancer, we all know estrogen, breast, bad. Do we know that for sure? Remember, we had the Women's Health Initiative had two arms, the people with hysterectomies who just had the estrogen, the people without the hysterectomies who had estrogen and progesterone. The initial data and even the continued we now have 11 years of data, an additional 7 years after the original study was closed. They've recontacted women, they've looked at the breast data again, and it's saying the same thing it said initially. In the estrogen and progesterone arm, there's an increased risk of breast cancer. In the estrogen alone, there's no increased risk in both breast cancer or breast cancer deaths. So what Dr. Martins was saying before, estrogen good, progesterone bad, that may not be, that's simplifying it, but again, to me, I need to simplify things to get through my day, because otherwise I look like that picture. And so that's what's important that information somehow has not gotten into the press. All the bad stuff did, but the good stuff never seems to make it. This is for everybody out there who likes this statistic-y kind of stuff. What's circled are all the things that improved with either estrogen and progesterone or estrogen alone in the Women's Health Initiative. I'm not going to spend time on that because I hate those kind of statistic-y things. So I'm going to go to this one. To me, this is the money slide. Okay? This is what I can say to patients. I'm going to compare you cases per 1,000 women who started estrogen from ages 50 to 59, and that's, again, assuming that's in that 5 to 10-year range. So if you had menopause at 55, it might be a little bit older, versus no hormone therapy at all. So how many people will have heart disease? Estrogen and progesterone, estrogen alone, it's still better. It's much better with just estrogen. But there's 3.8 women per 1,000, or 3.8 women less per 1,000 with cardiovascular disease than without hormone therapy. And if we look at the bad numbers, breast cancer, estrogen and progesterone, 7 per 1,000. That's starting to get a little bit more dicey. But if we look at estrogen alone, it's minus 1.5. So again, I think this is the take-home slide. This is what patients can understand. You show a patient or you try to explain this to a patient, that's not going to work. Try to explain that to me, it doesn't work very well. You try to explain that to me, I can get my head around that. North American Menopause Society 2012, treatment greater than 5 years was linked to the increase in breast cancer. So that's another thing to remember. It's that 5-year mark that seems to be significant. Unfortunately, even after you stop the hormone replacement, that increased risk, estrogen and progesterone, that increased risk continues. Does that decreased risk continue after estrogen alone? I don't know that. I don't know if there's data out there. Do you know? I don't know if there's data out there. Okay, so estrogen, again, we already said estrogen alone, not a problem. So it's complicated and it's hard and it takes a lot of time, right? So why should we bother? One big reason to bother, why do people ask for estrogen? Well, why do people complain about most? They don't come in and say, I'm worried about my risk of heart disease. They come in because they're having hot flashes and they need systemic treatment for hot flashes. Or they come in with the urogenital, well, it's not, it's the genital, what's the new terminology, which I realized I did it wrong, genital, GSM, genital urinary syndrome of menopause. Thank you. I realized I put it wrong. It's right later on in the lecture. Again, for that, local treatment is appropriate. Vasomotor symptoms, what's recommended is the lowest effective dose, and you need to use it systemically. I didn't put any recommended doses here because there's so many different estrogen preparations. In general, the equivalent of, people talk about 0.3 of Premarin, which is kind of the lowest dose. I usually don't start people who are newly menopausal on the lowest dose because if it doesn't work, they're not going to go higher. A general rule of thumb, people aren't going to go higher. They'll go lower. So I usually start them a little higher on either 0.625 or 0.45 mostly. And then if they're feeling better, after a while, I try to drop it down. Transdermal therapies may decrease the thrombotic risk versus the oral preparation. I think that's pretty well established. And again, no evidence that one estrogen is better than another. When should you kind of push for the transdermal? People like pills. I'm happy giving people pills. When should you try to push the transdermals a little bit? People who have a little bit more of a clotting risk than average people. Hypertension, the bad lipids, diabetes, obesity. Okay, and again, in these people, again, you have to look at that risk benefit for taking estrogens at all. I don't treat these as contraindications. Progesterone or Progestin, again, we talked about that. Progestin is kind of the enemy. The standard of care is the Provera 10 milligrams or the micronized progesterone in a cyclic fashion. I don't think many of us use a cyclic fashion anymore at all. Most of us use either the continuous, or the alternatives is to do it every 3 months so that you withdraw every 3 months, as opposed to it's less progesterone or progestin overall. Or you can use different routes. You can use vaginal progesterone gels, which they're kind of more compounded, and we'll talk about that in a little bit. Or the Mirena, or the other Laletta, progesterone-containing IUD. Again, these are not, they are being used to protect the endometrium. Long-term data is not out there, but I think it's looking pretty good. For women intolerant of progesterones, or people who just don't want to take progesterones, or people who you counsel, maybe you should think about not taking progesterones, you can do annual endometrial monitoring with ultrasound or endometrial sampling. New in hormone therapy, again, talked about it a little bit before. Duovi is 0.45 of conjugated estrogens and 20 milligrams of, I can never pronounce any of these words, it's a SERM. It's shown in vitro in animal studies to be inhibitory to breast cancer cell growth. So that's what's really exciting about this, is you're taking that major risk that progesterone adds, and you're hopefully eliminating that risk. We don't have the hard and fast data to say that yet, because it's just going out there. I think any new estrogen is probably, Dr. Martins was talking about it, having a hard time being sold. I don't know about you guys, but I have a hard time, like Dr. Martins, selling estrogen to anybody. People don't want to take it. They're scared to death of it. But I think we should really try to advocate for what is good for the patient. Contraindications, you all know these. If you're going to give estrogen, consider doing a pre-hormone therapy workup. The fasting lipid profile, evaluate for cardiovascular disease and risk factors if they're over 60. Again, you can be over 60 and still within 5 to 10 years. And make sure that you follow up on their mammograms. Encourage the patient to try to taper the dose every 6 to 12 months to see what happens to their symptoms. About 50% of them will need to resume it. I used to tell people that 2% of women would have hot flashes for the rest of their lives. I've heard updated data the other day or at a conference recently that said it's up to 20% will have hot flashes for the rest of their life, which makes more sense to me clinically from what I see in the office. Stopping abruptly or tapering doesn't matter. Either way, you're going to still get the same effects if you're going to get them. And again, we're still trying to aim for that 5-year use, because that 5-year use seems to be an important trigger point for the breast cancer risk in the combined therapy. After stopping hormone therapy, what happens? Again, unfortunately, when you take away the estrogen, you lose the benefits of it again. Except the breast cancer risk, if you have progesterone, stays around. So again, depends on age, timing, risk. Best candidates are the newly menopausal women with low baseline risk of heart disease, low absolute risk of adverse events. Duration, again, we're trying to avoid long-term duration. there we go. Genitourinary syndrome of menopause. See, they make everything harder. It's the new terminology for vulvovaginal atrophy. And that's the definition, just because I know I'm probably getting close to my time, if not over already. Local low-dose vaginal estrogens, creams, rings, tablets. We don't need to add a progestin in most cases. Long-term use is recommended because, again, it's estrogen deficiency, not estrogen withdrawal, giving us those symptoms. There's even some suggestions to use it as a preventative treatment for vaginal atrophy. Use the minimal effective dose. Ospemifene, I'm just going to mention, which I think is a very new and exciting drug for vaginal dryness, has the FDA indication for dyspareunia. The only two drugs that have that indication are Premarin and ospemifene. It's an oral selective estrogen receptor modulator. It's a daily dose. It not only improves the symptoms, but it's also working like estrogen in the vagina. It's improving the maturational index and improving correcting the vaginal pH with no endometrial activity. Unfortunately, we still have to get that perfect serum that does that for us without giving us the hot flashes, so that's a little bit of a limitation on it for immediate postmenopausal women. And I have question, protective against breast cancer. I think it's going to be, but I can't really officially say that yet. Last thing, patient perspective. We know what the patient perspective is. They're scared, they're confused, everybody tells them not to do it. They will have specific symptoms that concern them, so try to tailor treatment to this concern. They're all afraid of cancer, so make sure you can give them accurate information. That's where that how many women in 1,000 chart is very helpful. Most will decline systemic hormone therapy because they're looking for alternatives. So you need to know the alternatives. Do I know the alternatives? Not very well. That's a whole nother lecture, and I will admit that as a deficiency. Bioidentical hormones, I just want to mention, they are not an alternative to hormone therapy. They are hormone therapy. ACOG's statement is there's no scientific evidence supporting the safety or efficacy of compounded bioidentical hormones. That is a website that gives a very nice summary of bioidenticals. I am not anti-bioidentical, although if I had to take a stand, I would be. Patients who will only use bioidentical hormones, I will prescribe them with all the warnings that come with regular hormone therapy. And I will think back at that slide with all the crazy lines. Don't check levels. It's not going to help. Many available over-the-counter preparations. Very few have randomized controlled trials. They have limited safety data. The only one that I know, I'm sure there's more and people can correct me. If you know any, I'm happy to hear about them. Ramifemin black cohash has safety data up to 6 months of use. It is very effective for hot flashes, and it doesn't have interference with other medications. That one I will mention the brand name because Ramifemin is the brand name, and I know that they have good quality control. For vasomotor symptoms, SSRIs, Brisdel, which is the only FDA-approved SSRI, but there are any of them help at least a little bit. Clonidine, I don't know if anybody uses clonidine anymore. I tend not to use it very much. Ice water, for people who don't want anything but don't want hot flashes, carry around a thing of ice water. When you get a hot flash, take a big swig. You lower your core body temperature. It actually works. Vulvovaginal atrophy, if you don't want or can't use estrogen, lubricants and moisturizers. And I go over that more in the sexual dysfunction. And I think that's where I end. So hopefully I'm not too late. Okay.
We have time for a couple of questions, too. But, yes, ma'am.
How are you defining newly menopausal?
When I say newly menopausal, I'm defining within 5 to 10 years of menopause. So perimenopausal, will I start people who are perimenopausal on hormone therapy who are still getting cycles? Yes. If they have no contraindications, I try to put them on a low-dose birth control pill until I don't get all that. It's very hard to regulate bleeding when people are still getting periods, even though they're irregular, and I wind up chasing bleeding that I know is nothing, but I have to prove is nothing.
Yes, sir.
2 questions. what endometrial thickening are you using for your patients, and how often are you doing endometrial biopsies, and when do you stop?
I am using a thickness of 4 millimeters, less than 4. So I'm using less than 4 as my thickness. I know it bounces back and forth between 3 and 4. I also have the advantage of we do a lot of our ultrasounds in office, so 3 or 4 can also be variable based on if it looks cystic or if there's other lesions in it. I would only do an endometrial biopsy once a year if I thought it was necessary. When do you stop? I would stop after they stop taking any. If they're taking just estrogen, I will stop when they stop taking the estrogen, as long as there's no postmenopausal bleeding.
Yeah, and the studies, when we're doing studies for new drugs, the FDA says less than 4, so it's 3. And the second thing is, we can do trials on any estrogen without a progesterone for 12 months or 13 months. And all the studies we've done, and all the studies the FDA has done, if you have a negative first biopsy, no one's developed anything in 13 months. So you know when you respond.
I don't do a biopsy before I start it. I don't know if
No,
that.
the studies we do. So we know
yeah.
the exact time that nothing happens in 12 months. So if you go a year, so 6 months later, you don't have to do. You get an ultrasound for some other reason. It's 4. It was 3. Don't do it into a biopsy.
So if you're thinking, you just do a biopsy, or you do saline?
You can do. You just do a random.
Got a measurement before, or?
We get a measurement before, and then if it's 4 or greater, we go ahead and do a pipelle. Just do a suction through it, and then that's it. Yes, sir.
Your summary slide of the estrogen versus the estrogen progesterone complications risk. Estrogen decreases breast cancer, helps bones. I think I saw the estrogen progesterone total mortality was less in the combination.
It is. It's still total mortality is less.
Explain the total mortality being less with the progesterone.
Well, it's the benefit from colorectal cancer plus the benefit from osteoporosis outweighed the increase in breast cancer risk. Because if you get a fracture, you're 67, 70, you get a fracture, there's a higher mortality with that.
Right.
So overall,
that slide alone would to use progesterone.
Yeah, I mean you can, and people do. I mean it's just with the original project for the WHI was to show that estrogen and progesterone decrease cardiovascular mortality was good for your heart. That's what we were all touting before the study came out. So, but then the individual risk, and when the breast cancer risk was too high, they stopped that study. It wasn't in the estrogen arm; they kept the estrogen arm going, and it stopped. And then they stopped it eventually. The interesting, if it's a nice meeting besides the Southern Medical Association to go to is North American Menopause Society. It's a gigantic meeting; thousands of people go there, and they have some of their, wonderful. They have wonderful plenary speakers. They do stupid things like I'm on the committee to change the name because atrophy is a bad connotation to it, so they had to confuse us. But the last year, the lead speaker, he was a Nobel Prize winner, and he won the prize for developing the SERMs. And the first thing he said, which shocked everybody, is that estrogen doesn't cause breast cancer. He said, in fact, estrogen kills breast cancer cells. That's how I started. He says, 30 years ago, that's how I started my research. We knew that if you cultivated breast cancer cells with estrogen, it killed them. So I was trying to find a better estrogen. I wanted to find an estrogen that killed breast cancer but didn't have the cardiovascular side effects. He said he failed, to find a safer, but he proved that the SERMs, which were selective, would decrease breast cancer risk just like estrogen itself does. So that, to me, in my mind, it shows that estrogen by itself isn't the problem. It's progesterone, not just any progesterone, but synthetic progesterones that interact. Just so as you see, there's a difference in your effect on bone and other things when you add the progesterone to it, because there are 2 different hormones that act differently on different receptors. But the overall mortality was down, and that's why we didn't look back and said, oh, look, what did we do with all those women? The ones who have breast cancer, yes, it was bad, but overall mortality was slightly down, but not statistically significant.
I'll double check. I'll make sure that I didn't reverse those because the initial chart I had it the other way. So I'll double check that I didn't reverse those.
Yeah, there wasn't an increase in mortality. There was a slight,
right.
But nothing significant. All right, thanks very much. We're gonna. Oh, one more question. Go ahead.
Women who've had
With lipids, Dr. DePetty is going to talk about lipids, right?
We can talk about it.
All right.
I think look at the other risk factors for heart disease and whether or not they have already developed heart disease. And you have to look at the other markers. Okay.
Thank you.